number one, when does menopause happen, right? Like we're talking the now times, not the Golden Girls. This is not a 70-year-old event. This is a now time event. And then realizing that, a lot of people think menopause just means hot flashes and no periods. And instead of being like, no periods and hot flashes are a consequence of what's happening. It's not actually the happening, right? And the happening is us outliving the life of our ovary hormone production. So then you get hot flashes because hormones are low. You get no periods because hormones are low. And then you get muscle atrophy and then tissue atrophy, loss of collagen, loss of blood flow, all of those things. So hormones are simply molecules that help our bodies function.
There you are, magic.
Hi.
Hi.
Look who I brought.
Who's that?
This is Rosie.
Oh, Rosie likes kisses.
Oh, Rosie's 3 months old. She's so sweet.
Oh, I had postpartum depression when I got a puppy.
Believe it, man. Just disrupt your sleep.
They are a lot of work.
They're a lot of work.
Oh my gosh. If you do it right, they're a lot of work.
Yeah. If you don't care, you're
Correct.
just going to have a very, very destroyed house.
Yes. No, I don't want that. So I thought it would be amazing if we start with like a really quick, I know you can, like the 3-sentence intro on who you are so people have some sort of context.
Totally. So I'm Dr. Kelly Casperson. I am a urologist, puppy frog lover extraordinaire. And I started speaking about female sex ed, which then kind of led into hormones. And now I got a 5-year-old podcast and turned in the second book manuscript this morning, and just kind of became the thought leader on why don't we know what we're supposed to know about all of this?
Yeah. We don't know what we're supposed to know, which is part of the reason we're talking. What I love about your work, by the way, I send your podcast to like somebody every single day.
Thank you.
I love your podcast. I'm like, I need to create a study guide out of it. Just like somebody asks this question, I'm like, there's the podcast.
Right.
But what I love about your work is that I'm a pelvic floor movement therapist, and I know that you are a big fan of us.
Yeah.
So I love that you're not just in this silo of your own beliefs, and that you believe in the whole body, and you believe in the power of the body, and you believe that we're not broken, which is something I've been, harping on about for so many years. So I love that we have that in common. But I do think, that being said, while I feel like I do this amazing job covering the pelvic floor exercise aspect, I do feel like so many women they arrive at the gates of their 40s or surgical, reasons of menopause, right? So surgical, non-surgical, but like they arrive at these gates with no information about what's about to happen to their pelvic floor. So I wanted to have this conversation because I feel like we owe it to our client base that no matter how amazing and powerful their pelvic floor is, because of all the amazing, powerful exercises they're doing, there's stuff to know. There's like real kind of hard science stuff to understand. I was hoping you could kind of dispel that. So I was just like diving right into it. We're standing at the gates. What do you want us to know?
I think the biggest thing in midlife is the myth of what menopause actually is. I think people think first of all, think of somebody in menopause and your brain will go to a white-haired 70-year-old, right? So that's the first like societal, like, oh, it's not the Golden Girls. Like it's 45, it's 48, it's 53. Yeah. These aren't people who are like in Palm Springs who haven't had a job in 30 years. This is like the high functioning now times.
Yeah.
Right.
It's us. It's you and I.
It's us.
Powerful women getting stuff done. Yeah.
Totally. So I think the first thing is just the stigma around like who's allowed to be in menopause. And then when you realize like, no, we got to shift this down and like truly believe that like midlife, it's a blessing we get to call it that. Because 40 and 50 is only halfway done. If we're lucky and we do it right. Right. So like,
we have half our life to spend in this phase.
Yes. So like people are like, just the term midlife, I think is like amazingly optimistic. because you're like, dude, you know what that means? And like, you already know how to drive and tie your shoes and like cook, like all the skill, right? So it's like, you got all this adult time now.
Yeah.
Which is really
right. Which is adventure.
And like being super intentional, is like, you've learned to read, you've learned to hold down a job, you've learned a lot of things. Now you get to be intentional. What do you want to create?
The tagline of my business is move with intention.
Totally. I think it's a big waking up time for people of like, hey, maybe you found yourself on a treadmill and you're like, is this it? Right. And then realizing like the amazing gift that awakening can be.
Yeah, I agree with you. I think that embracing it as a time of power is what you're saying. Let's embrace this moment as a time of power. But I think that part then coming along with that power is education. Like, I don't really want to be anyone's uneducated. Like, I don't want to have to go to the doctor to get educated. No offense to you. I love you. I would go to you and like, you can do anything you want to me. Well, but like, you're the only person I want to go to for education. Right. I want to I want to know what I'm talking about when I go in for that appointment.
Totally. And like, doctors don't have time to educate at this point. You've got a 15-minute a doctor's appointment, and like the more prepared you can be on your way in, because the level of conversation I can have with women who are like, this is what I'm experiencing, this is what I think it is, this is what I want to try, and like, you're already at a whole nother level of like, I don't even know what menopause is. I don't know what hormones do. I don't know that hormones are safe, right? So it's like your education will get you to a conversation that you can't otherwise have.
Totally. So the pelvic floor, the vagina, and the vulva change a lot during this phase. We want to know all about those changes. What happens? Like, things change, and it doesn't have to be scary. People are always like, you're such a fear monger. I'm like, I'm actually anything but. I'm in service to the vagina. I am like bowing down to the menopausal vagina. But can we please just know what happens so we can bow down with a lot of like reverence?
Yeah, I mean, isn't it amazing that like people who are trying to educate be accused of scaring people? Is like, what's scarier than an uneducated populace?
Yeah, not much.
Not much.
I mean, so,
to me, I'm like, dude, sometimes some of this stuff is just truth. And if it makes people feel scared, like, well, knowledge can be scary, but it's at the end of the day empowering. So you think the other thing, so number one, when does menopause happen, right? Like we're talking the now times, not the golden girls. This is not a 70-year-old event. This is a now time event. And then realizing that, a lot of people think menopause just means hot flashes and no periods. And instead of being like, no periods and hot flashes are a consequence of what's happening. It's not actually the happening, right? And the happening is us outliving the life of our ovary hormone production. So then you get hot flashes because hormones are low. You get no periods because hormones are low. And then you get muscle atrophy, and then tissue atrophy, loss of collagen, loss of blood flow, all of those things. So hormones are simply molecules that help our bodies function. That's all they are. They are not otherwise scary. They basically help cells function. They help mitochondria function. So if you take away, I don't want to call them food, but in an analogy, is like if you take away the nutrients, the body still survives. We're not dying over this. We're just not functioning like we functioned when we had hormones. Right. So that's what happens to the pelvis. And the big long term is GSM, or genital urinary syndrome of menopause, which takes an entire breath to say.
But it's such a proper term compared to like the senile. What was it? The senile. Yeah. I mean, talk about golden girls. No wonder nobody wants to be in menopause when we think our vaginas are going to be senile.
I know.
I mean, GSM is so much kinder and empowering. It explains what's happening.
Yeah, totally. So it's the common ones: pain with insertion into the vagina, bladder urgency and leakage, it hurting when you pee, more susceptible to bacterial infections of the bladder and the vagina, pelvic floor laxity, you lose your muscle strength, prolapse, you really see prolapse kick in.
Oh yeah. I mean, prolapse is one of the main things I work with. Yes.
And nobody knows what that is. They all think they're dying. They all think it's a tumor. right?
Well, and they feel very broken. I mean, I know people from other cultures where prolapse is not seen as a big deal. And these clients of mine have prolapse and they're like, why is everybody panicking? I think that how you feel about your prolapse is also very cultural. We
Yeah.
live in a society that like adorns the vagina as this on this altar of unrealistic, so much unrealistic stuff that when there's an issue, we are made to feel so broken. Right?
Yeah. Yeah. I liken it to like you go to the dentist and you have a cavity, and if you think it's a personality flaw, it's like, it's not a personality flaw.
Right.
It's okay. But it's
Yes,
like
that's so true.
women don't exercise, they don't take hormones, they have big babies, and a lot of them, like, the fact is, like, why are we actually surprised prolapse is happening?
Yeah, and why can't we also be a little bit more accepting about the body's changes while being proactive to try to help it? Like, why are we fear mongering? Why are we pathologizing every single thing that happens rather than just working on solutions to help support?
Well, I see, in my practice, I see a lot of people, they come in, they were told they have a prolapse just on a pap smear, they had a pelvic exam or something. You have a prolapse, completely asymptomatic, does not affect them at all. They don't feel anything. They pee just fine.
Go home,
Sex is
and then they
fine.
have, right.
But they're like, I've got
Yeah.
this thing. And I'm like,
Yeah.
but does it bother you? They're like, no. And I'm like,
Yeah.
that we don't care what they said about your pelvis. You had a baby, there's some laxity. It doesn't bother you.
Well, you can have 3 different providers diagnose you with 3 different types of prolapse and then tell you it's not a prolapse, it's a GI issue. I mean, the problem is also prolapse is very kind of misunderstood or easy to misdiagnose or...
Yeah. Oh, totally. And it has good and bad days.
Yes.
You
Depending on
might
where
have a
you
bad.
are. Yeah, totally.
Did you poop? Were you exercising this morning? Like, your
Right.
prolapse can have good and bad days. So it might look like prolapse on Tuesday and then the next day. So how I talk to women about it is I kind of break it down into, is this surgical prolapse or is this prolapse? Because then it kind of breaks it, like, otherwise it's like prolapse has to be fixed. It's like, it does not have to be fixed if it's not causing dysfunction in your day to day.
So I've had a lot of clients who had a prolapse postpartum. They then start doing work with me. The prolapse, I always say, I'm always honest. I'm like, prolapse doesn't actually go away. No, like, I don't want to be an a-hole here, but you can become asymptomatic and the prolapse can change. But being asymptomatic for a lot of people means I healed my prolapse, which is great enough for me. And it gets them back to what they love. And they go back to their exercises and their routines and their jumping and their running and they're happy. But if a doctor were to check in there still might be a prolapse, but they're not feeling it anymore.
Yep.
So, but then they hit menopause. And the prolapse comes right back. And it is devastating because they've had maybe 10 years without any symptoms and they've felt so empowered. And this is where I have to have the conversation where I'm like, well, I'm not a doctor, but let's talk about estrogen. Mm-hmm. Oh, and by the way, here's a podcast by Kelly Casperson that you should listen to help you understand why estrogen. So I would love to talk about the big E, estrogen, and how it does affect everything from the brain to the pelvic floor. Specifically, I'd love to focus on the pelvic floor, but and that it can, like you said, prolapse is a big thing that shows up for people in menopause. But I see it as showing up again after they've already healed a prolapse. It's back and they're pissed. And then it gets better when they help it with the biggest taboo that you can say in my communities, which I'm not part of any community anymore, but the communities I used to run in, where God forbid you helped yourself with estrogen, which I just want to say to everyone, the minute I turn 50, that is getting all over my vagina. I'm 47, so.
Oh yeah, and your face, if you want.
I already use it on my face. Yeah, so estrogen's already going on my face for sure. Totally. For sure.
So yeah, I mean, estrogen helps cells. So collagen, connective tissue, blood vessel elasticity, the thickness and integrity of skin, right? So it's not like estrogen helps one thing and that's why it helps the pelvis. Is like, it helps all the things because it helps all cells. Yeah. It helps nerve cells, it helps muscle cells, it helps skin cells, it helps like all of the connective tissue cells that are, in between. So the cells that secrete moisture. So like, it's literally nutrients for your body. And it's just this is my theory on it, is never as a large population have we ever lived this long together.
Right.
And we are the first generation, the Gen X and the younger boomers are the first generation where we've seen the boomers age poorly. And so now we're like, okay, let's not just accept another day as another day until we die, but let's try to not be doing that when we're 84.
Hence the longevity like craze right now, right?
Yeah. And
we're like all about vaginal longevity.
Yeah, exactly. Like hormones are female longevity.
Yeah. And the elephant in the room that I know people are commenting on is like cancer. And so like, before we go any further in this, we really need to dispel the whole cancer. First of all, vaginal estrogen. I want to really hear you say it and not me say it, versus HRT. And then in general, HRT and cancer and that whole debacle.
Yeah. So vaginal estrogen is skincare. What I mean by that, because people get confused of like, how does it not go into your body? It's about dosing. So vaginal estrogen is very low dose, low concentration. You can measure your blood and you'll still have, if you don't take hormones otherwise, it will not look like you have any hormones in your body because it's really
it's not systemic.
Dose.
Using it vaginally is amazing. You're saying it's amazing for your pelvic floor, for prolapse, for UTI, for all these things.
Yeah.
I
tell women, I say,
it's not going into your bloodstream.
Going into your bloodstream. So I tell, if you do a loading dose, asterisks, because there's always asterisks in medicine, right? If you do a loading dose, some people will do daily times 2 weeks and then twice a week. I don't do loading doses in my practice. And the reason is a lot of these people are coming in with years of no hormones, and then I'm pushing a big load on them for that. There's no data for a loading dose. It's kind of a wives' tale of why it exists in the first place. And you will get some systemic absorption because your skin is so thin and it's such a higher dose doing it daily. Yeah. So they will say, I've got headaches, I got some breast tenderness, I kind of got a little moody. And that's why I don't do loading doses. So
yeah, I've heard that before. I've heard that from clients of mine too. Yeah. Yeah.
And the way to do it is just, hey, back off a little bit, wait for the skin to get healthy, and then go. The standard dose for vaginal tabs and creams is twice a week.
And I think a lot of people don't realize that there is a vaginal HRT, MHT. There's a vaginal hormone therapy replacement, and then there's systemic, and they're two very, very different. And what we're talking about here right now.
Yeah, and only to be like, complicated, because medicine is there's one vaginal product that is systemic dosing. It's called Femring. Most people don't use it because it's very expensive, but it's nice because it's plug and play, and it covers both your pelvic floor needs, your pelvic health needs, and your systemic. But just to be like, in medicine, it's never black and white of like all vaginal products are local. Well, there's one vaginal product that's systemic.
That's helpful to know. I know you love the cream because you love putting it on, the outside of the vagina, which is known as the vulva, can have atrophy. People can lose their labia minora, and the clitoris can adhere, phimosis, right? Yeah. The clitoris can adhere to the hood. There all sorts of atrophy can happen, and you like putting it on the vulva. I understood. Yeah. I think I understand that.
Yeah,
for that reason.
One of the very common places for pain with intimacy is that, if my hand can be a vulva, is the 6 o'clock gets very thinned right here. And so I like to put the cream there, massage it, non-sexual touch, just get your body used to massage and touch and put the cream there. Whereas if you just put a tab in the vagina, it doesn't cover, it's not like skincare. So and the other thing about the cream that I really like is it's the cheapest product on the market right now. So I can always get fancier, but basic works for a lot of people. And this isn't like an antibiotic where you just take it for a week and you're good. This is until you take it to the grave. Because what a lot of people don't understand is if you stop taking your vaginal estrogen, you'll go back to functioning with no hormones again.
So I have a client that had been on vaginal. She had a very forward-thinking doctor. This client is 76. She had a very forward-thinking doctor. And when she was like 45, the doctor was like, let's protect your vagina and get you on the estrogen cream. This client, I know.
Years ago?
Yes. Yes. This client never got, I know. Boston, like there's like some progressive thinkers there. This client,
there's some good sex med docs in Boston.
Yeah, I know. It's amazing. I went to high school there. But this client never went on systemic HRT. So only on vaginal local. Then recently went on vacation, forgot her forgot her cream. Was like, you know what? I've been on it for so many years. I wonder what would happen if I just stopped using it, stopped taking it while she was on vacation. Wouldn't you know, for the first time in her whole life, got incontinence, was leaking and was like, what is going on? I'm like, I've had my whole life. I've never had incontinence. So she immediately, this is a person who happens to also be a nurse. So she's like, she was like, wait, critical thinking. Let me get that HRT back in there. Boom. 2 weeks later, the incontinence gone, stayed gone. She's like, I'm never getting off it again. I mean, it's amazing. It's just incredible.
It's amazing. I mean, it helps the integrity of the urethra, right? And the pelvic floor. And so it's like, it's not crazy to like, it's like, once you understand what estrogen does, you're like, of course it helps the bladder function better. Estrogen, actually, the muscle of the bladder called the trigone has estrogen receptors in it. And they've actually done studies where they like give those bladders estrogen, they can biopsy them and like actually see the muscle get healthier, of like way less spasticity, way more strength, a lot less leaking. And leaking's common. And leaking is the number one reason people end up in a nursing home.
Yeah. And then also like urinary tract infections. Can we talk about how those can kill you too? And that, isn't it something like it can help 68%? Is that the number?
I always say 50 to 60 because there's a couple of studies. But this is how, when most women who come see me now are pretty educated because they know what I do and they come in. They're
paying attention.
Give me your things, right? So I'm not usually like being like, estrogen doesn't kill you. Like I don't have to do all the like background work because I have. But so I say, hey, if I had something that decreased your risk of having another UTI by about half, would you be interested in that? And they're like, yeah. And I'm like, that's vaginal estrogen.
And we're talking the non-systemic, put it on your vagina, rub it on your vulva cream. We're not talking about the hormonal replacement that people are still so terrified of.
And I mean, that's the thing is, even if you did the systemic, that doesn't decrease urinary tract infections. Because the systemic still very low dose. And the other myth is that if you're on systemic, you can't be on vaginal estrogen. You can be on all the things. And to me, I'm like, this is simple math. Systemic dose plus something that doesn't increase systemic levels equals systemic dose. You're not increasing your hormone levels by doing both. And systemic hormones are still very low. We're not replacing.
People are terrified of them.
We let a genie out of a bottle in 2002 that I don't know if we're ever going to get it back in. But people are trying now that we're 22 years after it. But it's in the ether, it's in the zeitgeist, and fear sells. So it's a big project to try to get women not afraid of something their body naturally makes.
Haven't I heard you say that being on, and maybe I'm wrong here, so correct me, but that taking systemic now, HRT or MHT, whatever term you want to use, can increase lifespan? Have I heard you say that?
Multiple studies increases your lifespan by 3 to 4 years.
I mean, but everybody thinks it kills you.
If men had a drug that would make them live 3 years longer, do you think they'd all be on it?
Yes. Do you think that every person should take, if that's the case, do you think every woman should take systemic HRT?
I will never say that publicly.
Okay. But this is not a public forum.
Yeah, Instagram's
very private here. We're having a cozy chat. Okay.
I can say the 2022 guidelines menopause guidelines say for the average healthy woman between the ages of 50 and 60, the benefits outweigh the risks. What you need to know about that statement, that's a very strong statement. To say the benefits outweigh the risks for a medication is actually a very strong, it sounds very nice and medical, but that's actually saying a lot.
Yeah. Yeah. That's like a big vote of confidence.
This is what I like to tell people to think about. It's a very high bar to get the nation or the world to take something. We don't do that for baby aspirin. We don't do that for statins. We don't do that for hardly nothing. Do we tell a nation to take a medication, right? Very high bar. Now, when we're talking on the individual level, we say, you get to make whatever decision you want to make. It's your body, you're educated. All the data points to, if you want to live long enough, doing it with hormones in your body will give you a preservation of function better than not having hormones. And you know, I think that's where the longevity movement is winning, if you ask me, because what do doctors do? Doctors treat disease. That's what we do. We're very bad at actually being like, how can I keep you highly functioning for 30 years? That's not what we do.
Right.
And so doctors will say like, well, if you're suffering enough, you can have hormones. If you're sick enough, you can have hormones. If you have hot flashes enough, you can have hormones. And the longevity movement is like, how about we prevent disease? How about we prevent osteoporosis? How about we prevent, heart attacks? How about we prevent diabetes? And here's an interesting statistic. If you take women who are just starting menopause, so perimenopause, menopause, if you take pre-diabetics, so blood sugar issues, but they're not diabetic, and you start them on hormones, 1 year later, the hormones have prevented diabetes 30% more than the people who didn't take hormones. If there was a drug that could decrease the risk of diabetes by 30%, there'd be a Super Bowl ad for it.
Yeah, it's
right?
So amazing that it does so much good and yet gets so much hate because people are still so stuck on this study that was flawed and not even, it wasn't even a study, wasn't it? It was even a study that was looking at heart outcomes, right? Wasn't it a heart outcome study that then became
the Women's Health Initiative?
Yes.
The Women's Health Initiative was an NIH-sponsored, government-sponsored study looking at, if we give you hormones, will it prevent heart disease, heart attacks, cardiovascular issues? Because we had data that wasn't a randomized controlled trial, but we have data in the 90s that say women are getting less heart attacks, they're getting less strokes, they're just doing so much better, but let's prove it. So this study came in to prove that putting people on hormones decreased cardiovascular disease. But cardiovascular disease happens very slowly. And if I looked at 40 or 50-year-olds, I'm going to need a 30-year study versus if I look at 65-year-olds.
Right.
So the average age of the study was 63.
Yeah, they weren't letting in people, right? They were starting, you couldn't be in the study, I think, if you were younger, I can't remember, 60 or something?
Yeah. They had some young people, but the average age was 63 because they needed cardiovascular disease to happen, right? So you need to pick the older people. So this study doesn't apply to, if you're 50, does this study apply to you? It's like, no, because it studied 63-year-olds. It studied 70-year-olds. They were some smokers, overweight. Yeah. Some people already had cardiovascular, right? So it's like, when you look at a study and you want to interpret it of how does this apply to you, were you being studied? No, you weren't. You're healthy. You don't have heart disease. You're I'm making it up. It's like you're 48, whatever you are, of like, this study doesn't apply to you. And in addition, the biggest problem with this study was that they went to the media and they said, we're stopping it because of concern of breast cancer. And when the shit hit the fan, there was not an increased risk of breast cancer amongst the people who took the hormones. But media, we love turning, media.
We love drama,
heads.
Of course.
What is scarier than breast cancer? And to this day, I mean, this is what's so interesting. What's the number one killer of women?
Heart disease, isn't it?
Heart disease. Heart disease. And so what's the number one killer of women between the ages of 40 and 60? Heart disease.
Heart disease, yeah.
But it's like, and the other statistic is like breast cancer is 95% curable now. So we're afraid of the wrong thing. And I'm not here to tell people to not be afraid of breast cancer, but I'm here to be like, we're afraid of the wrong thing. Like the marketing on this is all messed up. You know?
Yeah. And I see a bunch of people asking questions. They want to understand also conditions like endometriosis and estrogen, if you could speak to that just a little bit, because a lot of people who follow me do have endometriosis and pelvic pain, all the kind of uterine overactive bladder.
Yep. So I always say I'm not a gynecologist, so I'm not an endometriosis expert. I can say this. The data supports, so you had endometriosis or you had it treated or it bothers you less and you're in the perimenopause menopause transition. The big myth is you can't take hormones because you have a history of that. That's not true. I have many women with treated endometriosis who are now on hormone replacement therapy, and it's like anecdotally rare that it flares in endometriosis. So we want to make things simple. We want black and white. We want to know what's good and bad. And we can't say that estrogen is bad in endometriosis. We don't understand endometriosis fully.
No.
And so to withhold very beneficial things from something we don't fully understand, that's easy, but it might not be right.
And then as far as vaginal estrogen, I find that people with endometriosis have a very tight pelvic floor as well, because endometriosis causes stress and pain. And when you're in stress and pain, you grip and tighten and you control what you can control. And muscularly, you can control your jaw and your pelvic floor very well and your hands. But people will control their abdomen. They'll tighten their abs, which will tighten your pelvic floor. They are synergistic. You cannot tighten one, they go together. And so people start tightening and clenching because they're in pain. So we have a lot of hypertonic pelvic floor and endometriosis. And I have found anecdotally, of course, I don't run clinical science studies, so this is all just like anecdotal what I see. But there's a lot of also prolapse that then starts happening with all the tension and tightness and stress and gripping and clenching.
Draining.
And then we get this cascade. Yes. And then exactly. And now we get this cascade of kind of pelvic floor conditions that, while again, the movement stuff is phenomenal, movement doesn't replace estrogen as much as I wished it did. I wished I could sell that. Like, I really wish I could sell that. Just do my programs.
Some of the fitness influencers are trying to sell that, my friends. They're like,
I know Jade Egg stuff.
And I'm like, what do you mean we don't advise hormones? Unless you're prescribing hormones, you shouldn't have an opinion about if all of women should or shouldn't. To me, I'm like, that's overreach. Just like I should not be giving anybody a pelvic floor exercise plan. Like, I should not do that. But I know enough to be like, you better have a pelvic floor physical therapist if that's happening. But I call it I call it, especially pain with sex, I call it the three-legged stool of like, I'm going to take care of your hormones down there. You need a pelvic physical therapist to help take care of the pain and the muscles. And you need a sex therapist to work on how this is affecting that.
Well, that's the other thing. You can't separate those things.
And I'm like, that's my three-legged stool of pelvic pain. And some people are like, I want to do one thing at a time. And I'm like, you won't get as better as my ladies who do all three. The stool falls apart. You need all three legs.
And it also speaks to the fact that I have a lot of clients who are incredibly strong and fit getting pelvic floor dysfunction with menopause, because again, it is a chemical. We're talking about like a hormonal change in your body that no amount of fitness and protein and eating well and doing Lauren Ohayen's programs, like none of that is we can't change the hormonal process in your body. Your best bet is to understand it and then make an educated choice about what you want to do about it.
That's exactly right. And I think that goes back to how you started of like, get educated, because then you understand. Otherwise people are like, well, I'm just going to try to do this. And it's like, great. But that's not what's happening right now. This is also happening. Right. And it's like, the more you educate people on it, and it's like, pelvic floor physical therapists, they get it. They get vaginal estrogen like most people don't get it, And so it's like, it's so wonderful that they're like, if you want to get the most better, let's address everything.
100%. And again, I'm not being a doctor. I don't prescribe, recommend, advise anything. But when I have literally thousands of clients over the age of 40, I would be an a-hole if I didn't say, there's this thing, this treatment too, that goes really hand in hand with my work. Check out hormone, like localized systemic, because I've seen it do wonders, like literally do wonders for people's pelvic floor.
It's embarrassing how much of a win you get from it, right?
And how people are still being told by their doctors that they're not good candidates. And it's like, you don't have again, I'm not a doctor, I can't speak to that, but why are doctors withholding this from women? Why are we, if there was if men had penile atrophy and a cream could help them, you better believe it. Well, I mean, Viagra is similar, right?
Viagra is the most recognized drug in the world.
Yeah, exactly.
And so,
why are they getting all the attention?
The other thing that women get is, when men don't get this, is women get, are you suffering enough?
Right.
You have to prove your level of suffering. Whereas if a man's like, I have erectile dysfunction, we're never like, is it enough erectile dysfunction? Like,
show me how much. Right.
Like, no. So women have to go to the doctor and then they have to prove their level of suffering. Whereas men don't have to do that. Men say, I have low libido. And they say, but is it enough low libido?
Because we're expected to, again, we're expected to age a certain way. We're expected to be golden girls. We're expected to break a hip. We're expected to be a risk factor for this, that, and the other. Arming an entire generation, an entire age with really good information would actually put a lot of people out of business.
Yeah.
A lot of people would stop making money if we really educated people about their choices.
Oh, yeah, 100%. And I mean, I think the other thing is we know women are dropping out of the workforce because of untreated menopause symptoms. We've got data. It's to the tune of billions of dollars a year. And so that's why some companies are like, hey, how do we keep these people functioning, right? Because at the end of the day, it turns into a big economic issue if you can't work and function.
Yeah. And I have a lot of clients with pelvic floor dysfunction, again, in perimenopause and menopause, who it is a quality of life changer. It can make you suicidal. I have multiple clients who have felt suicidal from the all of it. And these are people who, again, are fit and healthy and eating right. There's this myth that it happens to the unfit and unhealthy. Yep. It doesn't. It's that's not how it works. Well, but of course,
the myth perpetuates, social media is just eat enough soy, just do enough HIIT, just lift heavy enough weights. Of ovaries, there's always a grain of truth. Cigarette smoking, horrible for ovaries, right? Some things age ovaries. Yeah. But it's you can't outsmart the clock. And the other thing is listen, if your ears wear out, you get hearing aids. If your eyes wear out, you get eyeglasses. If your teeth wear out, you get new teeth. If your hip wears out, you get a new hip. If your ovaries wear out, you get buttercup.
Wine. You get a glass of wine. Yeah. And a puppy.
Puppy. Yeah, exactly. So it's if we're being very biased about what's okay to replace and what's not okay to replace. And it's very judgy.
Yeah, I agree. Well, I'm so happy we had this conversation. I think that it answers. I saw a lot of comments of people saying, I had no idea there was such a thing as a localized estrogen that could actually help my thin vaginal walls and pain and UTI. There is there. And again, I'm not pushing anything. I have nothing to sell. I don't have an affiliate code for some estrogen cream. I just really want people to feel better. And as a movement therapist who specializes in pelvic floor, I see that what misinformation gets you. I see so strongly what it gets you. And then the power of what options get you.
Yeah.
And I know that because I've done my research, I know what choice I plan to make for myself, which is not what everybody else needs to do. But I know where I'm going to be with the vaginal estrogen stuff. Yeah.
I mean, I would say most educated, whether they're menopause experts, pelvic floor physical therapists, the people who like know, and it means like, why wait to suffer? Why wait till you have recurrent UTIs?
Yeah.
Why it's kind of like, why wait till you have a sunburn to be like, oh, maybe sunscreen, right? Is like, if you can do something that's cheap and safe and effective, why wouldn't you prevent? Like, why wait till your clitoris is atrophied? Why wait
And
till like,
yeah. And it doesn't, I mean, it helps, but you can't unatrophy it, right?
we don't have a lot of studies, but I've made vulvas beautiful again, very commonly. It might be
Okay, that's good to
different
know.
doses. Yeah, different doses for different people. I love the vaginal DHEA. It makes beautiful
Oh yeah,
vulvas.
I've heard amazing things about that.
So I like, you can make vulvas live again, but it's not guaranteed I can get your labia back. But we try.
Yeah, better not to lose it to begin with,
Yeah.
right? Which is where preventative and preemptive health works. Somebody was asking about how it helps your bladder. I mean, besides the fact that they're like flatmates, would you just quickly speak to that, and then we can say goodbye?
Yeah. So I always say that vaginal estrogen is a bladder medication. We're just getting it there via the vagina.
Yeah.
So the vagina and the bladder share a wall. So I say they're condo mates because they share a wall.
Yeah.
And so you put the estrogen in the vagina, you go to bed, it soaks into the wall, and on the other side is the muscle of the bladder called the trigone, which has estrogen receptors. The urethra has estrogen receptors. So it's just getting to the bladder via the vagina.
Yeah, and it works really, really well. I mean, it works also.
It works as good as the overactive bladder medications do. So traditionally, if you go to a urologist, they're going to give you overactive bladder medications for urgency. What am I talking about? Urgency, frequency, getting up at night to pee, leaking with urge, leaking with running water. That's overactive bladder. Traditionally, you're going to get an overactive bladder medication, which has dry mouth, constipation, and associated dementia. Like, they're nasty meds. I don't like them. And if you come and see me, I'm like, vaginal estrogen, pelvic floor physical therapy. I can tune most people up with that. And I'm like, that's the most natural you can get. We're restoring function. We're not drugging it. We're restoring function.
Yeah, exactly. I love that you say that, because again, once estrogen declines, it has dramatic changes systemically, but we're talking about the vagina and the vulva. There are big changes that happen when the estrogen goes down. So, yeah, and I love this idea of getting to it before the atrophy begins.
Yeah, I mean, because I'm a urologist, I see worst case scenarios come into my office every day. It's like 7 diapers a day, bad leakage. And it's like, it's hard to walk that back versus come on in when it's starting to be a problem. We'll get your physical therapy going. We'll get your hormones going. And hopefully we're never going to get to the point where you're in 7 diapers a day.
Yeah.
Not to scare people by saying some people wear 7 diapers a day when they're 70, but that's decline of function. That's what it is. That's what it looks like.
That is decline also of function and estrogen. And again, there is this, like, when people start losing function, they also start losing the will to move and the will to help themselves. And now we're not moving as much. And now we're not. So it's like, it's hard to pinpoint, well, what's the chicken and what's the egg? Because those two go very hand in hand. When people have an injury or an osis or an itis or any of those things, they stop wanting to help themselves. And the less you help yourself, the more less blood flow, right? Less blood flow, and then less this and less that, and less estrogen, less blood flow, less working of all this whole system. And it's not an amazing situation.
Yeah. I mean, I always tell people, I'm like, I can't do the physical therapy for you. Right? Like, you can't just go, because some people are like, just give me a pill. And it's like retraining that belief system to be like, the answer is not in believe me, the answer is not in an overactive bladder medication.
Yeah, an overactive bladder, this is a different conversation, but I see it in a lot of my clients way over diagnosed, misdiagnosed, and then they actually start getting the help they need and they suddenly no longer had an overactive bladder. I don't know if you see that, but I get a lot
all
of
day, every day.
that.
I see it a lot with interstitial cystitis. I have interstitial
cystitis. Exactly.
And it's rare. We'll just say it's rarely interstitial cystitis.
Well, because people are being diagnosed, any pain they have is being any pain,
GSM
bladder
all
pain.
the time. People are like, ever since my vaginal estrogen, my interstitial cystitis hasn't acted up. And I'm like, because you never had interstitial cystitis. You had the thing that most people have in midlife called GSM.
Yeah, this has been amazing. We have kept almost 400 people engaged this entire conversation, which is just so awesome. I love that. I thought we would be a good power duo, and I'm happy that we are. Thank you for so much for doing this with us. I've been wanting to chat with you for a while, and
it's my pleasure.
Bugged
it's
the F out of you.
until we get to a point where everybody on here knows what vaginal estrogen is and that it's safe and it's good. We've got a lot of work to do, you know?
We do. We have a lot of work to do. And so I appreciate that we're doing this. Let's just keep doing it. Thank you, everyone who engaged. Thank you,
Absolutely.
Dr. Casperson. And
until next time.
We'll do it next time. Thank you. Goodbye to the dog, too.
Bye.
Bye.